Okay, unfortunately, Dr. Annunziata had a conflict, and so she's going to give her lecture on September 30th. So I switched with her, and I'm giving the lecture today on small cell lung cancer. And then our second speaker today is Jim Gulley, and he'll be talking about prostate cancer. So and then in terms of announcements, we now have one PowerPoint posted at the website. So that's ccr.cancer.gov/courses/TRACO. And then the video cast is now archived. So the first lecture, you can call this up at any time on your computer. It's http://videocast.nih.gov, and you click past events, then you click lectures, you scroll down to TRACO and hit TRACO. And actually, if you do it this way, you'll find lectures from 10 years ago of TRACO. We have over 100 lectures posted. So everything that gets posted, it stays there. And then you'll notice one interesting thing is my address has changed to my phone number because my office was moved last week from Building 31 to Shady Grove. So that's good for the 20 people at Shady Grove because now you can come down to 2W130 and pick up handouts in my office. So that'll help you. Okay, so we're going to lecture then about the small cell lung cancer. And this cancer kills about 25,000 patients in the US annually. So this is about 1/6 of all the lung cancer patients that die. And all the other types of cancer are non-small cell lung cancer. That's epithelial cancer. Small cell lung cancer is a neuroendocrine cancer. So it's responsive to both chemotherapy and radiation therapy, and patients respond initially and the tumors get smaller, but then relapse occurs and the tumors grow and they're often unresponsive then to chemotherapy. So the median survival time is less than 1 year. So the small cell lung cancer, this is a biopsy specimen, H&E. You see sort of very small cells. What you really see are just the nuclei in dark purple, and there's very little cytoplasm in pink. And you see it's sort of very ordered, these small cells. And then when you look at them under the electron microscope, you see these granules. And these are neuroendocrine granules, like what you see in neurons. And so as a result, the small cell lung cancer makes and secretes growth factors. So lung cancer symptoms. Well, the first is the cough. And then you have chest pain. Your nerves are sensitive to all the inflammation. You have shortness of breath because part of the lung is being taken over by the tumor, and you can no longer exchange gases, the CO2 for the oxygen. Oftentimes, people will then get infections with bacteria, pneumonia, or they'll have bronchitis. And then worst of all is if you cough up blood, because then that's an indication that your cancer's of one of the higher stages. So traditionally, it's done using chest X-ray, but then one can also do bronchoscopy, whereby they stick a tube down your throat and look for tumors. You can do needle aspiration, stick a small pin into the tumor and see if you get tumor cells. You can remove lung fluids with thoracentesis and look for cancer cells in the fluids. You can do surgery of the lung. And what's vogue right now is spiral CT. So a big study was done by the Division of Cancer Prevention about 5 years ago, and it showed that if you have spiral CT and then it's treated, if the patient has tumor cells, then you'll reduce cancer incidence on the order of 15%. And so 15% of 100,000 people is 15,000 people. So lung cancer, we're always talking about big numbers. So this is a chest x-ray, and here you see a tumor on the left. It's a fairly large tumor. This is a CT scan where we see there's a tumor here on the left, and then with treatment, this tumor becomes much smaller. And this is the bronchoscopy, where you stick the tube down the throat, and here you see a tumor on the left. Unfortunately, usually lung cancer is detected when it's in stage 3. Stage 4, it's undergone metastasis, so that's bad. And we can sort of stage it again using the CT scan, MRI, PET scanning. You'll have a lecture by Peter Troike a little later on in the class about using isotopes such as fluorodeoxyglucose in cancer cells. We'll take this up more readily than normal cells. You have radionuclide scanning as well as bone scanning. Lung cancer undergoes metastasis to the bone. And then here in mediastinoscopy, you're looking at lymph nodes for tumor cells. So generally, if a patient has no therapy, their survival time is on the order of 4 to 5 months. If you do surgery, if the patient is in stage 1, you'll increase the survival time a little bit. Radiotherapy will also increase the survival time a little bit. And these are some of the agents that are used in chemotherapy. So we used to have a lecture in TRACO on chemotherapy, but now we emphasize newer drugs, such as tyrosine kinase inhibitors. So agents like carboplatin and cisplatin impair DNA repair, so the cancer cells can't correct the genetic material once a mutation has occurred. An alkylating agent is cyclophosphamide as well as ifosfamide. And then other agents are topoisomerase inhibitors. You'll hear a lecture by Yves Pommier next week on this. So topoisomerase inhibitors include irinotecan, topotecan, and VP16. And then we have agents that intercalate into the DNA, such as doxorubicin and epirubicin. And then we have antimitotic agents. Gemcitabine is very popular right now. Vinorelbine is also used. And then we have agents that impair tubulin, such as vincristine and Taxol. So you'll note then that the chemotherapeutic agents work by different mechanisms. So in the 70s then, the clinicians started giving combination chemotherapy. So if you gave cyclophosphamide, this inhibits this is an alkylating agent. Doxorubicin is antimitotic. And VP16 is a topoisomerase inhibitors. So these 3 different drugs work by different mechanisms. You combine them to the patient. The clinicians, they abbreviate this combination CDE for cyclophosphamide, doxorubicin, and VP16. You see other combinations are doxorubicin and vincristine, etoposide and cisplatin, VP16 ifosfamide, and Taxol, and isophosphamide, carboplatin, and VP16. So this combination chemotherapy, it was very popular in the 80s, 90s, and 2000s, but the result was, for lung cancer, very disappointing. After 50 years of chemotherapy, it really didn't do that much for the patients, and it certainly didn't cure the cancer. So you see here an approach is to use radiotherapy combined with chemotherapy, and this increased survival from 10 to 34 months, and a 5-year survival from 6% to 30%. So a combination then of radiotherapy and chemotherapy can be beneficial in small cell lung cancer, but still the patients are going to die. So initially, small cell lung cancer often responds to chemotherapy, but then the patients undergo relapse, and the chemotherapy becomes ineffective. And this results primarily because of the field effect. And with lung cancer, it takes so long for it to develop, 20 to 30 years, that initially you have one clone of cells. And this first clone grows out, may be responsive to chemotherapy, and so that clone is killed. But then the second clone grows out. The second clone of cells is resistant to chemotherapy, and that's what kills the patient. So this is what's referred to as the field effect. And then small cell lung cancer undergoes metastasis from the lung to the liver, the bone, the adrenals, the lymph nodes, and then the ultimate killer is when it gets in the brain. And usually when it undergoes metastasis to the brain, the patient dies within a matter of weeks. So, some cancers, the carcinogenic process is well known, such as colon cancer, but for small cell lung cancer, we really don't know anything about how it develops and where it comes from. In the lung, there's these neuroendocrine Kolchitsky cells. We don't know if this is a precursor for small cell lung cancer or if it's stem cells. And so the carcinogenic process of small cell lung cancer is still relatively unknown, and we really don't have very good animal models yet to study it. But we mentioned last time about smoke has nicotine metabolites, and N and K can function as a carcinogen. But the smoke also has nicotine, and nicotine binds to acetylcholine receptors on lung cancer cells, causing AKT phosphorylation. And you remember from last week, AKT, when it gets phosphorylated, it increases survival of the cancer cells. They're more difficult then to kill. And NNK forms DNA adducts, and if cells do not undergo apoptosis, mutations accumulate. And NNK can also cause AKT phosphorylation. So we're going to end this lecture, not quite yet, in about 30 minutes, and we're going to discuss ways about nicotine replacement therapy to get people to stop smoking cigarettes. But you see, there's a problem with that already, because if we're giving nicotine replacement therapy, the nicotine will still stimulate the cancer cells to grow. So if you do use nicotine replacement therapy, you want to use it for as short a period of time as you need to. And one interesting thing is we can tell who's a smoker and who's not, because there's this one metabolite, N-Now, which accumulates in the urine of patients who are exposed to cigarette smoke. And so for many years, the tobacco companies were very resistant about the fact that their cigarettes were causing lung cancer. And how did you know that a patient was actually a smoker? And then when they developed this assay, the cigarette companies got very quiet because then they had absolute proof of who had been exposed to cigarette smoke. And we note it's actually increased in non-smokers who breathe in cigarette smoke as well. So secondhand smoke you can also detect. So one of the advantages of working in this field, and I started working in it in the 80s, was that we had so many cell lines. And so here at NCI in the 80s, they'd get biopsy specimens from patients, and these biopsy specimens then, they were mechanically dissociated, and cell suspensions were made by passing the cell suspension through steel mesh. And then the cells were cultured in a serum-free medium. And the serum-free medium contains selenium, IGF-1, and transferrin. And the normal cells died, but about 1 out of 6 of the biopsy specimens, small cell lung cancer cells, would then grow out. And then you had a group of cells from a particular patient. And so these lung cancer cells, we see then that they need transferrin for iron transport and growth. They need IGF-1. IGF-1 binds to a tyrosine kinase receptor to stimulate growth. And one of the things that we found is this peptide growth factor, bombesin, or gastrin-releasing peptide, bound to receptors and also stimulated the growth. So over in the 80s then, from 1982 to 84, they established 31 small cell lung cancer cell lines. And so we have a lot to work with in the lab. Most cancers, such as prostate cancer, you have maybe a dozen cell lines. Breast cancer, a couple dozen perhaps. But for lung cancer, we have hundreds of cell lines. And they were neuroendocrine cell lines because they had high levels of this enzyme, dopa decarboxylase, that makes catecholamines. They had high levels of a neuronal enzyme, neural-specific enolase. And then they had high levels of these bombesin-like peptides. And over a 20-year period, over 100 small cell lung cancer cell lines were established and 100 non-small cell lung cancer cell lines. So we have lots of cells then to work with. And so then a goal became using animal models. And one animal model was using the AJ mice. You could expose these mice to urethane, and they would get adenomas, these white nodules that appear as bumps on the surface of the mouse lung. And so we found then that the adenomas especially would metabolize phospholipids into arachidonic acid. And then especially in the adenomas, they had cyclooxygenase enzymes that would produce prostaglandins. So here's an assay where we found that we could inhibit growth with indomethacin, which is a non-steroidal anti-inflammatory drug, or aspirin. So aspirin is used to prevent colon cancer. And the growth inhibition caused by the non-steroidal anti-inflammatory drugs was reversed when we added prostaglandin E2 back. So that suggested then that the prostaglandin E2, it wasn't just working through an enzyme, it was also working through a receptor. So here's using an animal model whereby we have small cell lung cancer xenografts growing in AJ mice. This is actually the adenoma number. And you see when we inject the urethane, it takes about 3 months for tumors to form. And then by the 4th month, there's about 20 tumors per lung in the untreated animal. And in animals treated with indomethacin, there was about 30% less. And if you didn't inject any urethane, any carcinogen, you didn't get any tumor. So looking at the immunocytochemistry in these mouse lungs, we found then that there was COX-2 immunostaining as indicated by these brown dots in the adenoma, as well as other areas of the lung. And this is just the corresponding H&E of the normal lung. We see lots of pink here because these are non-cancerous cells, so they have lots of cytoplasm. And so the COX-2 then, there was intense staining in the bronchus, whereby epithelial cells would stain, in the bronchioles, where there was staining again in epithelial cells, and in the alveoli, where there was moderate staining in type 2 cells, and then the adenoma also had immunoreactivity for COX-2. So COX-2 is an inducible enzyme that's in cancer cells. COX-1 is a housekeeping enzyme that's present in all cells. Indomethacin inhibits both COX-2 as well as COX-1. We see with COX-2, we can induce it by adding EGF. So you see we get a substantial increase when we add EGF. The monoclonal antibody 108 blocks the increase. And then the EGF receptor can also be phosphorylated by the prostaglandin E2. We mentioned previously that growth factors such as transforming growth factor alpha and EGF cause EGF receptor tyrosine phosphorylation. Well, in this case, the process occurs through a G protein coupled receptor. And once the G protein coupled receptor is activated, it causes release of TGF alpha, resulting in phosphorylation of the EGF receptor. This process is called transactivation. And it's inhibited by a prostaglandin E2 blocker. The drug is abbreviated AH in this particular slide. So PGE2, in addition to causing EGF receptor tyrosine phosphorylation, it causes tyrosine phosphorylation of phospho-ERK, and phospho-ERK can then go into the nucleus and stimulate production of transcription factors. And another thing that we found is the cancer cells will actually make vascular endothelial cell growth factor, VEGF, which is an angiogenic factor. And so PGE2 would increase the VEGF about twofold. EGF would also increase it about twofold. And then when we added this drug H89, which blocks cyclic AMP production, the effects of prostaglandin were reversed. So then the prostaglandin E2 works through cyclic AMP, causing adenylate cyclase activation. So the process is we see COX-2 will cause phospholipid production, leading to PGE2 production, which can then bind to this EP2 receptor, stimulating cyclic AMP, which will then activate protein kinase A, causing Krebs phosphorylation and altered VEGF expression. So it takes a few seconds to increase cyclic AMP. It takes about an hour to phosphorylate Krebs. It takes about 24 hours to increase VEGF production. When we look at transactivation, once we have the EP2 receptor activated, that can activate the kinase SARC, leading to TGF alpha release, which can then cause EGF receptor tyrosine phosphorylation. So this is a fascinating process then, whereby one drug, PGE2, it can cause all these downstream events, and then in turn, it can cause EGF receptor tyrosine phosphorylation, which will then increase COX-2 production, and this is an autocrine cycle right here. So the traditional COX inhibitors, such as indomethacin or aspirin, can cause stomach ulcers, and subsequently new drugs were developed, such as celecoxib, which is selected for COX-2, and it has minimal stomach side effects. So celecoxib then is in various clinical trials to see if it can function as a therapeutic agent in lung cancer. So, looking at genetic events then, we mentioned before with lung cancer, you have dozens of genetic events that occur over a 20-year period. And we talked before about P53 and how it gets inactivated. But other things that get inactivated are the retinoblastoma gene, the FIT gene, and then BCL2 gets overexpressed. So P53, we mentioned, plays a role in the G1 to S phase transition, and P53 drives programmed cell death by apoptosis after DNA damage. But if P53 is mutated, the damaged DNA then leads to cancer cell formation. For the retinoblastoma gene, you can have a variety of events going on, such as truncations, deletions, nonsense mutations, and splicing abnormalities. And this can occur in many lung cancer patients. And the RB protein is absent or abnormal in 90% of the small cell lung cancer patients. But with RB, we really don't have any good drugs to increase, to have its normal activity return. The FIT gene is called fragile histidine triad. It's located on chromosome 3P, and this is where a lot of deletions occur in lung cancer patients. But FIT protein expression is associated with smoking, and it remains to be determined if FIT is a tumor suppressor gene in lung cancer. BCL2 suppresses apoptosis and inhibits responses to chemotherapy and radiotherapy. So one thing they're trying is antisense to BCL2 in therapeutic trials. And so one company is promoting the use of Genesense. But all of these are trials. We really don't have anything that works very well in small cell lung cancer. We mentioned there's loss of chromosomes, especially in 3P, 4P, 4Q, 5Q, 8Q, 9P, 10Q, 13Q, 17P, 22Q. Smoking takes so long, 2 decades, that there's just tremendous genetic abnormalities. And there's also microsatellite instabilities, MYC overexpression in about 30% of the cases. And one growth factor we're going to talk about is stem cell factor. And c-KIT is a receptor tyrosine kinase. And we'll also be talking about Bombesin GRP overexpression. So 3P deletion is an early event, and 5Q, 13Q, and 17P deletions occur later. And in lung cancer, there's also microsatellite alterations where there is a laddering of short tandem DNA repeat sequences at multiple loci. This laddering may result from mutations in DNA mismatch repair enzymes. The microsatellite instability may be useful for the early diagnosis of lung cancer using sputum, bronchial washings, or blood. And finally, the MYC genes, NMYC and LMYC, are amplified in small cell lung cancer, and MYC heterodimerizes with MAX and functions as a transcription factor, facilitating cell cycle expression. And a more recent thing that they found is the inactivation of the LKB1. This is a serine threonine kinase that's inactivated in about 50% of the small cell lung cancer patients. LKB1 causes phosphorylation of AMP-activated protein kinase, AMPK, resulting in tumor growth suppression. So we'll take a look at some of the receptor tyrosine kinases in small cell lung cancer at this point. And the big one is IGF-1. And IGF-1 binds to the alpha subunit, but it's an alpha-2, beta-2 heterodimer. This then results in protein tyrosine phosphorylation, ultimately leading to ERK tyrosine phosphorylation and growth. So we had an antibody then to the IGF-1 receptor called alpha IR3, and it bound to the binding subunit, the 90 kilodalton protein subunit. And this alpha IR3 functioned as a physiological antagonist. When we added the antibody then, the xenograft growth in nude mice was reduced by about 80 to 90%. So IGF-1 then enhances the survival of small cell lung cancer cells, and it works through AKT signaling, and so LY2940002, a PI3 kinase inhibitors, decreases the ability of IGF-1 as well as scatter factor to cause phosphorylation of the AKT. So here's a cartoon then illustrating the receptor tyrosine kinases and how they form dimers, activating PI3 kinase, causing AKT phosphorylation, and then BCL2 then inhibits the ability of caspases to be activated. So the growth factors then increase survival of the cancer cells because the cancer cells can't undergo apoptosis. Okay, so scatter factor then and c-KIT are present in approximately 70% of the small cell lung cancer cell lines examined, and the growth of c-KIT transected cell lines is further enhanced by IGF-1 or Bombesin. And we do have a drug for c-KIT stimulation. It's the drug Gleevec. We mentioned before that that was used for BCR-ABL, but at high concentrations, it can also inhibit the receptor tyrosine kinase c-KIT. So c-KIT, it's a large protein, 976 amino acids, 520 amino acids are extracellular, a single transmembrane domain, and then there's a 433 intracellular amino acid domain that has tyrosine kinase activity. And then in 1980, 81, we found that high concentrations of Bombesin-like peptides were present in small cell lung cancer cells. And so initially, we made a monoclonal antibody to neutralize the growth factor. The monoclonal antibody was called 2A11. So you see in mice that are untreated, as well as treated with control antibodies, you get large xenografts, and the xenografts are very small if the animals are treated with 2A11. And then in the 90s, we tried clinical trials, and unfortunately, only one patient out of 13 responded to the 2A11. So the clinical trials were then disbanded. And this leads to the old saying of scientists have many times cured cancer in mice, but very few times in humans. So this is why you do these preclinical studies, to get a drug that looks like it's going to be pretty good, but then in patients, 1 in 10, 1 in 100 of the drugs that are developed and are effective in the mice will actually work in the humans. So then we decided it was best to go after the receptor and develop drugs for that. And so here you see the G protein coupled receptor. It's much smaller than the receptor tyrosine kinase, only about 400 amino acids. And it crosses the membrane 7 times. The receptor tyrosine kinase only crosses the membrane once. And then the ligand binds to this extracellular amino acids. And note the intracellular amino acids, especially at the C-tail, are very few. To get a tyrosine kinase enzyme, you need on the order of 400 amino acids. Here we only have about 60. So what these G protein coupled receptors do then is they work through signal transduction. An interesting thing is the GRP receptor is on the X chromosome. And so then the female has twice as many X chromosomes as the males. So are they more susceptible to smoking and getting lung cancer? And initial studies suggested that that may be the case. And here we see signal transduction. So we're adding GRP to cancer cells, and we have the cancer cells loaded up with a dye, and within 30 seconds, we see the fluorescence is increasing in these cells, and most of the cells are fluorescing, and then after 3 minutes, it goes back down to normal. So we see an intense increase in second messenger production, in this case calcium, but it only lasts for a few minutes. So it's a very, very fast signal. Here's another way of looking at the calcium increase in cell suspension. You add the peptide, within seconds, the calcium goes up, and it stays up for about a minute, and then it starts to come down. And then we developed this one drug, a small molecule. You'll hear a lecture in October on small molecule inhibitors. This is one of them, and you see that it blocks the ability of Bombesin to increase the cytosolic calcium. Here you see the structure of this small molecule inhibitor. It's actually sort of looks like 3 amino acids. It looks like a tryptophan, and it looks like a phenylalanine, and this one actually looks more like a leucine than anything else. So then the chemists in the pharmaceutical firms as well as the biotechnology firms, they're very interested in making these small molecules. Here we see they can block the G protein coupled receptor, but in the clinic now they use these especially for receptor tyrosine kinase inhibitors. Here we see that Bombesin can also cause transactivation of the EGF receptor. We get about a 4-fold increase within a minute. And then this drug, the small molecule antagonist, will block the G protein coupled receptor so that the transactivation signal is lost. So EGF receptor tyrosine phosphorylation is always upstream from ERK phosphorylation. So looking at phospho-ERK, again, we see the Bombesin analog increases ERK tyrosine phosphorylation about 2-fold, and the antagonist blocks. But these antagonists, they're reversible. So the drug works for a while, but eventually it will fall off the receptor and get metabolized. But an interesting thing that we found is these G protein coupled receptors, they inhibit growth by themselves, but if you combine them then with gefitinib, we see even stronger growth inhibition. So a problem is that traditionally gefitinib is only active on patients with EGF receptor tyrosine mutations. But in this case, this cell has the wild type EGF receptor. We find we make it more potent to gefitinib by adding this G protein coupled receptor antagonist. So this is something we're looking at preclinically, and potentially then it can make patients with wild type EGF receptor more sensitive to gefitinib. And so we've already seen before how once you have the EGF receptor tyrosine phosphorylated, you can go through the PI3 kinase, AKT pathway, increasing survival. You can go through the RAS, RAF, MEK, ERK pathway, increasing proliferation. And then here we see Bombesin causes PI turnover, leading to increases in cytosolic calcium, as well as SRC activation. And then SRC in turn can stimulate a protease to metabolize pro-TGF alpha to TGF alpha, which can then bind to the EGF receptor. And it looks complicated, but all of this occurs within 1 minute. So it's very fast. And then we see that ERK gets phosphorylated within 5 minutes. And then ERK can go into the nucleus and stimulate proliferation. So another way that it can do it is through tyrosine phosphorylation of cytosolic kinases such as PIK, PAC, and paxillin. And when these get tyrosine phosphorylated, this increases then motility and migration. Ultimately, this leads to an increase in metastasis of the cancer cells. So in summary then, small cell lung cancer, it's a neuroendocrine tumor which initially responds to chemotherapy, but subsequently relapse occurs. And we have multiple clinical trials that are in progress to improve the treatment of small cell lung cancer patients. But as of this time, we really don't have anything that's effective like the tyrosine kinase inhibitors, gefitinib. So the best thing, one time I did a press interview at an AACR meeting. We presented a abstract on non-steroidal anti-inflammatory drugs reducing lung cancer growth. And so during the interview, it became very apparent what the reporters wanted to say, me to say, was that if you took drugs like aspirin, then it was okay to smoke because you wouldn't get cancer. And so they asked me then if I take aspirin, and I said, well, I can't. I'm allergic to it. I get stomach ulcers. And they all sort of started laughing. But then I said, the real thing is, if you want to avoid lung cancer, just get people to stop smoking. And so now we have developed a very nice program in the US for this to occur. And one is nicotine replacement therapy. This includes gum, Nicorette, patch, Nicoderm CQ, or nasal spray, Nicotrol. But we mentioned you don't want to do this too long because nicotine will actually stimulate the growth of the cancer cells. So you just want to use this, and then as soon as you can stop it, you want to stop it. Another thing is there's very effective pills. Bupropion is an antidepressant that's used. And also sometimes on TV, you see these commercials for Santix, which reduces smoking urge and withdrawal symptoms. But smoking cessation, the best way is just to stop smoking. And this is how most people quit, is they just go cold turkey after gradual cigarette reduction. Now, not everyone is successful the first time, so early failure is quite common. But then ultimately, once you quit smoking, there's many beneficial effects. Within 20 minutes after quitting, your blood pressure and heart rate decrease to normal levels. Within 12 hours, your carbon monoxide levels in the blood return to normal. The cigarettes have a lot of CO2 in them. Within 2 days, your sense of smell and taste returns. Within 9 months, there's a decrease in cough and shortness of breath. Within 10 years, the risk of heart disease from stroke is normal. The risk of dying from lung cancer is reduced by 50%. So in the US now, we have 45 million smokers, and about 16% will die from lung cancer. So that's a big number. That's 5 million. But now there's 45 million ex-smokers. So that's sort of the good news, is that the number of ex-smokers is increasing. And also the number of cancer survivors now is readily increasing. We now have over 12 million cancer survivors in this country that are living. So that number is readily increasing. So we're on the right track in this country. We just have to continue to use less and less cigarettes. And then here's some references that you can refer to. And that's about it for me. thank you for your attention. Are there any questions? So the small cell lung cancer, it was a real big problem in the 1980s. We had about 30% of the lung cancer patients dying from it. And then in 1985, they developed what's called the high filter cigarette. So the cigarette particles used to be very heavy, would drop down to the ground and go deep into the lung, causing the small cell lung cancer. But once they developed the high filter cigarette, then the particles were very small. And so small cell lung cancer started to decline, but adenocarcinoma of the lung started to increase dramatically. And that's the big one now that we need to focus on. So we mentioned before about how cancer changes with time. But in this case, you know, the best thing you can do really is to stop smoking, and then the lung cancer rates will decline dramatically. So we've done real good on this country. Other countries aren't so good. We're selling a lot of our cigarettes now to the Asian countries. And so China expects a dramatic increase in lung cancer in about 20 years. And they're working with NCI as to what they can do to respond to this potential epidemic of lung cancer that they anticipate coming up. Yes? Yes, the electronic cigarettes are quite controversial. In theory, what they're supposed to do is just produce less of the carcinogens, so they would be a safer cigarette. But, you know, no real clinical trials have been done at this point to say that they're entirely safe. And you wouldn't really know for 20 years. So the vote is still sort of out on that. But what's good now is the spiral CT. And the goal for that is to detect lung cancer early. And so that's becoming more popular in the States. And that's a good thing. Yes. See, a general thing is the big pharmaceutical companies, they don't want to have drugs for prevention, because if a patient has cancer and they give them a drug and the patient dies, they're not going to get sued. But if they go into prevention, if a patient then gets cancer, they're going to want to sue the drug company. So they don't want that. So a way sort of around that is using a device, such as the spiral CT. And then if you can detect it early in stage 1, the surgeon can go in, remove the tumor, and that's it. So there's a lot of hope for the spiral CT. Okay, so we're very pleased to have James Gulley lecture today, and he's the Director of Clinical Trials and the Deputy Chief of the Laboratory of Tumor Immunology and Biology. And he's in the Center for Cancer Research. The lecture today, Prostate Cancer Clinical Update. Jim.
Well, thank you so much. It's really a pleasure to be here. We have an active clinical program in prostate cancer, and I've been here for about a little over 15 years at the National Cancer Institute. So what we're going to do today is talk a little bit about prostate cancer, and we're going to talk first about giving you an overview about the disease, talking about local treatment options, and then talking about systemic treatment options, and then finally kind of where we're going from here. So as we go across, you'll see that we have a lot of data for some parts of prostate cancer, and then there's some big holes that we still have missing, like many cancers. But let me give you kind of a basic overview of treatment now for prostate cancer. So when you're first diagnosed with prostate cancer, often you have localized disease, and often you will respond to local therapy, and we'll talk about what local therapy options there are. But eventually, about a third or so of men will develop biochemical failure. They'll develop rising tumor markers, in this case PSA, following their local treatment, and often they'll be treated with hormonal therapy at some point. Eventually, the hormonal therapy will initially work very nicely, but eventually patients will start to progress despite the hormonal therapy. And then we'll talk about all of these other systemic agents that can be used in prostate cancer treatment. So what you also see is that most of these patients are asymptomatic. Even after they become metastatic, many patients will still remain asymptomatic until later on in the disease course. And this can drive some of our treatment decision points. Okay, so prostate cancer is the most common cancer among men in the United States. It's the most commonly diagnosed non-cutaneous cancer. And it's the second most common cause of cancer death, as we'll see in just a minute. 1 in 6 men during their lifetime will develop prostate cancer. So we have, 40 people in this room, half men. So, 20, we're talking 3 or 4 of you will develop prostate cancer. So here's the deaths for prostate cancer, and you can see here we're starting with 1930 going all the way up to 2009, here in 2010. What you can see is that lung cancer by far the #1 cause of cancer-related mortality, but prostate cancer is #2. And you can also see that both, all 3 actually, lung, prostate, and colon cancer are the big 3 in men. They're all coming down and have been coming down since the mid-1990s. So that's good news. What are risk factors for development of prostate cancer? Well, certainly age is a risk factor. As you get older, you're more likely to get prostate cancer. A family history of prostate cancer. So if you have 1 or 2 first-degree relatives, you have a significantly increased risk of getting prostate cancer. And first-degree relatives are either brother or father. Geographic location. So it turns out that the United States and Scandinavia has some of the highest rates of prostate cancer, and that Asians have a lower rate of prostate cancer. But it turns out that Asians living in Asia actually have a lower incidence, and when they migrate to the United States, or Scandinavian country, their risk for prostate cancer goes up. Race, there's also an increased risk of both lifetime risk and risk of death of prostate cancer for African Americans compared with Caucasians. So detection. Prostate cancer can be detected based on one of 3 things. You can be based on symptoms. Fortunately, in the United States, that is not usually what happens. Symptoms happen, as I showed you before, really late in the disease course. So most patients diagnosed in Western countries are not diagnosed based on symptoms. They're mostly diagnosed based on either PSA screening or digital rectal examination. So what do I mean when I say digital rectal examination? Okay, you can see here a person cut in sagittal view. You can see a gloved finger going up through the rectum, and you can actually feel the prostate there. Now, what I want you to do now is just to take your thumb and your forefinger, and what I want you to do is to pinch really tight, like you're trying to hang on to a piece of paper or something really thin. I want you to feel right here. This is your thenar eminence. This muscle part on your thumb, when it's taut like that, that's what a normal prostate should feel like. And what I want you to do is I want you to feel right over here on your knuckle. That's what prostate cancer feels like. So when the physician is feeling that in the digital rectal examination, they're just feeling for that. Is there any area that's hard like this? And is it in what area is it? And then they'll go in and potentially biopsy that area to see if indeed there's cancer there. So that's one way we use to detect it. The other way is by PSA. PSA is a simple blood test, an ELISA that can be done on serum from patients. Now, you'll notice that before the era of PSA screening, here's the number of cases per 100,000 men. And you can see right around here is when PSA screening became widespread in the United States. And all of a sudden, you got this huge increase in the incidence of prostate cancer, the number of patients being diagnosed with prostate cancer. And all the epidemiologists were saying, well, is this an epidemic of prostate cancer, or are we just biasing it because now we can detect it a lot earlier? And obviously, you see here, there was this peak, and then it flattened out again. So this was just a bias. We were able to catch it a lot earlier and treat men with a lot lower burden of disease. The question is, did this diagnosis of prostate cancer earlier, using PSA and digital rectal exam to screen, did that result in saving patients' lives? So there were two large prospective studies that were designed specifically to look at this. There was the PLCO trial funded by the National Cancer Institute, the prostate, lung, colon, and ovarian cancer screening clinical trial. And in that trial, they enrolled about 75,000 men. Okay, and the men were randomized to receive screening versus no screening. And after 7 years, they did a preliminary look at the data. And what they found was that in the screening cohort, 50 men died of prostate cancer versus 44 in the no screening cohort. Really, it was complete wash. Very few out of the 76,000 men had died from their prostate cancer. So perhaps it's too early, or perhaps there's not enough events to really get any conclusions. But it didn't seem, at least in this early look, and we're going to talk about what 7 years in prostate cancer means in a little bit. But at least in this early look, it didn't look like there was a big benefit to doing screening. Now, there's a trial done in Europe. It enrolled more than double the number of men, and they looked at those men by screening versus no screening. And they, about the same amount of time, a little bit longer follow-up, 9 years, there was a 20% reduction in the prostate cancer mortality. So one thing that one might say is, well, this is certainly a different patient population than the U.S. Certainly, the use of PSA screening is not as widely used there, so these patients may have been further advanced. Interestingly, about half of these men that were randomized to the no screening arm went ahead and got their PSA test done anyway at their local physician. So it's just too widespread use here. Maybe that diluted it. We just don't know yet. The full picture hopefully will be coming out later. We'll talk a little bit more about this when we talk about another trial too. So when you are diagnosed with prostate cancer, then what do you look at to look at the prognostic features? So there's several things we look at, and when you take the cancer out and look at it under the microscope, the pathologist will assign it a Gleason score. And that's really looking under the microscope and seeing, does this cancer look aggressive or not? The more aggressive it looks, the higher the number. And they'll take and they'll give it a score of between 1 and 5. And they'll take the most common area, the most common pattern that they see, and then they'll take the second most common pattern. And together, that'll be the Gleason score. And so you can get anywhere from 2 to 10 out of 10, although right now it's very uncommon to see anything less than a Gleason 6 tumor because of some of the changes in the Gleason grading pattern. So a primary pattern 3 is usually what you get, a 3, 4, or a 5. So usually you'll get a Gleason score between 6 and 10. And we'll talk more about that when we talk about some of our clinical trials. Staging for prostate cancer. So there have been some interesting staging changes in prostate cancer recently. It used to be just the anatomic staging, but now we've added in Gleason score and PSA, so that stage 1 you almost never see anymore because your PSA has to be low and your Gleason score has to be really low. And this is probably incidental tumor, and some people are arguing, and there's some editorials saying, we shouldn't call this cancer at all. We'll come back to that too. And then as it becomes palpable or locally advanced or metastatic, the stage goes up and the prognosis becomes worse with increases in stage. So prognosis then, we already talked about this a little bit. Prognosis is based in part on the PSA at diagnosis, how high it is. The higher the PSA, the worse it off for the patient. The percent of tumor in a biopsy specimen, so if you get more than 50% of a core being positive, that's a high amount of volume of tumor. The number of positive biopsies, typically a 12-core biopsies, so that you get 12 different areas of the prostate that are sampled. And if you get 2 or 3 of those positive, that's starting to be a large amount. If it's more than half of the biopsy samples positive, that's really high volume disease. Gleason scores we mentioned, all of these are important when looking at prognosis. Now you can take all of these factors and you can plug them into the different tables, nomograms that are online, and you can get what the predicted rate is for having the disease confined to the prostate or having it be outside of the prostate, involved in the lymph nodes. And you can have the prediction for how the patient is going to do with surgery or radiation therapy, how the patient would do in terms of progression-free survival, their probability. So treatment. Now, the rest of the talk, we're going to be talking about various different treatment modalities. So for patients who have a life expectancy of less than 10 years, or especially those patients who have a low Gleason score, so a Gleason 6 tumor, they may be candidates for active surveillance. And what do we mean by active surveillance? We mean we'll just continue to follow the PSA and perhaps do additional biopsies to see that the Gleason score isn't getting worse. In part, the data is based on this study. This was a study that showed that men that were either older or men that had especially low Gleason score tumors, those men actually did really well in terms of outcomes. So what you're seeing here is this is a box, and you can see the proportion of patients alive starting at 100% down to 0%. And what you can see in what's shaded in gray here is the overall survival, and the dark line is the deaths due to prostate cancer. So you can see that if you have a Gleason score that's, say, 5 or 6, you have very few deaths proportionally from prostate cancer. Most of the men that are going to die over this, and this is a 20-year follow-up time, are going to die from other causes besides prostate cancer. However, if you get a Gleason score of 7 or 8, you have a significant likelihood of dying from your prostate cancer, especially if you are younger. 90% of the patients that die from prostate cancer here, if they are not treated up front. So bottom line, low Gleason score, may not need to do anything. Older age, so if even with a more aggressive tumor, such as a Gleason 7 tumor, if you're 70 to 74, you only have a 40% chance of dying from prostate cancer and a 60% chance of dying from something else. Okay, so if you decide, well, you want to treat, but perhaps the patient either has a survival of expected less than 10 years, you might want to treat with androgen deprivation therapies. So these would be patients that either A, are not good surgical candidates or don't want local therapy, or patients that may have more aggressive disease but may have a lot of heart disease maybe, and therefore not good surgical candidates. So this was a study looking at androgen deprivation therapy given right up front versus waiting to give the androgen deprivation therapy, also known as hormonal therapy, later on when the patients developed progressive disease. And what you can see is there's about 1,000 patients enrolled. The hazard ratio was 1.25, favoring the use of early hormonal therapy, so about a 25% improvement in survival. And interestingly, most people would say that, well, if you start hormonal therapy earlier, you're just burning that bridge. What was interesting was that there was no earlier time until what we call castration-resistant prostate cancer, where they had progressed on the hormonal therapy, whether you started it up front or you waited to start it. So it probably was, if you waited to start it, you probably developed such a bulk of disease that when you came in with a hormonal therapy, it kind of blew through it more quickly. The disease-specific survival was reportedly not different, even though the overall survival was. And the overall survival was the primary endpoint. And there may be reasons for that, which we can talk about at some point. For patients who have a predicted survival of 10 years or more, and that is actually most of the patients that we see with prostate cancer, even though the median age is 71 years old, these are the treatment options. You can either do surgery, called radical prostatectomy, that's surgical removal of the prostate, external beam radiation therapy, or brachytherapy. This is the radioactive seeds that are implanted directly in the prostate. So we're going to talk about each of these in turn. First, surgery. So as I mentioned, surgery, radical prostatectomy is surgical removal of the prostate. Can be done with a variety of different approaches. And the most common side effects are actually impotence, which we'll talk about, and incontinence. Let me mention, before we talk about side effects, let me mention a recent trial that was published a couple of years ago, 2011, in the New England Journal of Medicine. In this trial, patients were randomized to receive surgery versus just watching the patient and not doing surgery. And what you can see was that there was an improvement in survival if you got the surgery versus this watchful waiting, which basically was treating the patients later on with a variety of different treatment options. And this was the overall group of patients. But what's even more interesting, I think, is this subgroup analysis. And that is, if you took the older men greater than or equal to age 65, you see there's really no difference here in either deaths from any cause, deaths from prostate cancer, or time to metastasis. But in the younger men, where you have a longer period of time that the patient is going to be alive, eventually you see this splitting of the curves that there's less competing causes of mortality. Okay, less people are going to die from their heart attack or their stroke, and more people are going to end up being affected by this. So it appeared that the majority, if not all of the benefit for the surgery was in this younger patient population. We'll come back to that in another trial where we see a very similar type of trend. Oh, right now we'll come to it. Okay, so this is a trial that was just published late last year, less than a year ago, and this was the PIVOT trial. This was the prostate intervention versus observation trial. It was done in the VA system. And what was interesting about this trial was you see there's really no big difference at all between observation and radical prostatectomy. So patients getting no surgery, and this is a U.S. trial. The other trial was a European study. So less of a difference here in the U.S., perhaps because we're finding the patients earlier, we're doing the PSA screening. And so that would suggest that maybe what we need to be focusing on is who has that lethal phenotype? Who are the patients that have the disease that really needs to be treated? Maybe we're finding too many patients here in the U.S. And so what you can see in this pretty busy forest plot, I just want to point out one thing here. And that is the same thing for both of these. So this is the deaths from any cause, overall survival, which is the primary endpoint of this study. You can see that those men that had a PSA greater than 10, the more advanced disease, those patients actually had a statistical benefit from getting the surgery. Conversely, those men with the low-risk disease, that's usually low Gleason and low PSA and low stage, they appeared to have no benefit and maybe even slight detriment from getting surgery, whereas the intermediate and high risk, they appeared to have the benefit from the surgery. So really what we need to focus in on, I think, is patients that have the lethal phenotype, the more aggressive, more advanced disease for surgery. Maybe many of those that have less advanced, less aggressive disease, those can just be watched. And there's lots of studies. It's actually changed the paradigm of how patients are being treated in the U.S. With this data. Okay, now let's shift gears and talk about radiation therapy. So what is external beam radiation therapy? Well, that is radiation to the prostate from outside of the body. So there's evidence that higher doses are associated with better outcomes, and this comes from a variety of different studies, and we've, over the decades, been able to increase the amount of radiation that we can give to the prostate and still spare the normal tissue. There's a new, about 10 years ago, this was new, intensity modulated radiation therapy that can really allow for a high amount of radiation directly to the tumor with sparing most of the normal tissue. And the most common side effects with radiation therapy also include impotence and rectal irritation. So like surgery, impotence is a big issue. So just to show you here, the radiation therapy in the lighter gray and the radical prostatectomy in the darker, you can see here that both of them are pretty bad overall when it comes to impotence. There's a quicker decline with surgery, and then there's a plateauing out, and it takes a little bit longer to get there to come down with the radiation therapy. But they both end up with about 50% of the men having decreased ability to get or maintain an erection that is sufficient for vaginal penetration. So why is that? So turns out that the neurovascular bundle that runs right next to the prostate here, this is the prostate right here, is what innervates the penis and allows for the erection. And you can see right there that if you were to come in with surgery and cut out this prostate, that you'd be interfering with that, especially if the tumor is near this part of the prostate. And certainly the same thing with the radiation, where the radiation goes through there too. So how do they do in terms of incontinence? This is urinary incontinence. That means dribbling or some leakage of urine. And you can see that it's much worse actually for surgery than it is for radiation, but they both take a little bit of a hit. And how about for bowel bother? So if you get some irritation in the bowel, you could have, it's worse with radiation. You can have patients that have multiple small bowel movements every day, but it's not nearly as bad as either the incontinence or the impotence. Okay. Final local therapy that we're going to talk about is brachytherapy. This is the implantation of seeds within the prostate. You can see right here on this x-ray, these are the pelvic bones here, and this is the prostate that has multiple seeds implanted. These are radioactive seeds that are permanently left in the prostate that give off the radiation over about a period of about a month. And then they're high dose, high amount of radiation, and then after that the radiation is gone. The nice thing for patients is this procedure is a one-day procedure. It can be done on an outpatient setting and doesn't require them to be hospitalized like surgery does, or doesn't require them to come back Monday through Friday for 15 minutes like external beam radiation does for up to 8 weeks. But really, I should say, brachytherapy is really only indicated for low risk or intermediate, perhaps intermediate risk tumors. High risk tumors, really there's no defined role for brachytherapy, certainly as a solitary modality. It can be combined with external beam radiation therapy. So treatment of locally advanced disease, we've talked about localized disease. Now how about locally advanced disease? Well, certainly in patients that aren't candidates for local therapy, perhaps you could just do conservative management, eventual hormonal therapy. For patients that elect to get radiation therapy, one can give radiation plus hormonal therapy, and there's also some data for surgery, hormonal therapy with surgery. So let's talk first about the radiation therapy. I'm just going to give you one example because of time of a clinical trial. This was the first clinical trial showing an improvement in overall survival if you combined hormonal therapy, we call androgen deprivation therapy, where you knock down levels of testosterone, and combine that with radiation therapy versus radiation therapy alone. This trial was a relatively small trial, but there have been at least 4 trials since, randomized trials, that have shown much the same data. And there's improved outcomes when you gave the combination, both in terms of local control of the tumor, so less symptoms locally, metastasis-free survival, so the patients didn't develop metastasis as quickly if they got the hormonal therapy up front, and most importantly, overall survival, 62% versus 78% at 5 years, and this was highly statistically significant. So let's talk now about surgery. There have been a variety of different studies looking at hormonal therapy, lowering the testosterone levels in patients with surgery, and there's been nothing that has improved, has had an impact on clinically significant endpoints, except for one trial in which patients with lymph node positive disease were, at time of surgery, and this was just microscopic disease. So at surgery, they took out the prostate, they took out some lymph nodes, and then they went very carefully, the lymph nodes were not enlarged, but they went very carefully and looked at this under the microscope and found that there were some cells of prostate cancer within those lymph nodes. They found that if you put those patients on hormonal therapy right away, those patients actually lived longer than patients who didn't get the hormonal therapy right away. And this trial was actually closed early because of the improved overall survival that was seen. So only 98 patients were enrolled on this study, and at 11 years, or almost 12 years of follow-up, you can see that 17 of 47 patients had died in the immediate androgen deprivation therapy, and 28 out of 51 had died in the delayed therapy group. So this was a hazard ratio of 1.84, so 84% increased risk of death in the delayed group. Now, it did, I mentioned it was not fully enrolled, and this probably is worse outcome than you'd expect for this group of patients. So there are some people that question this data, but it remains the best data to date, the only randomized trial to date we have in this patient population. So it is considered standard of care. Now, how about patients that undergo surgery and now are found to have still disease left behind? So their surgical margins are positive. When the pathologist looks at the prostate, he sees that the cancer is going right up until the very edge of the tissue that is obtained. Turns out that these patients are also benefited if they start hormonal therapy early. So this was a trial that enrolled about 425 patients that had positive margins, but no lymph nodes that were positive. And if they started hormonal therapy right away, radiation therapy right away, so radiation to the local area, you had improved metastasis-free survival and overall survival compared to observation, and this was statistically significant. And this was at a median follow-up of about 12 and a half years. So now let's go and talk about patients. We've talked about local therapy. How about patients whose PSA starts to rise, the third of patients that are not cured by the local therapy? What happens with those patients? What are the options for those patients? Well, this rising PSA could be due to local disease right there at the level of the prostate, and maybe those patients could get radiation still if they've had surgery before. Or it might be metastatic disease, and that could be metastatic disease that we can see on scans, or perhaps not. So options include additional local therapy, hormonal therapy, or just following the patient. And it's really difficult to look at this group of patients and say if it's going to impact their overall survival. And that's because of this data here. So this is a trial where about 2,000 patients who underwent radical prostatectomy were followed, and about 304 of them experienced a PSA relapse, a rising PSA. And of those 304, 103 of them went on to develop metastatic disease. And based on this data set, and this data set is from Hopkins, a single institution where most of these patients were treated by a single surgeon, none of the patients received hormonal therapy before having clinically significant metastatic disease. So that's very important. It allows really for looking at the natural history of prostate cancer. So the median time from PSA elevation to metastatic disease was 8 years. That's a long time. The median time to death after that was an additional 5 years. So you have your surgery here, average of 2 years before the PSA started to rise, an average of an additional 8 years before they developed metastatic disease, and an average of another 5 years before they died. Now, a lot of these patients had low Gleason scores. They were not very aggressive clinically. And this is kind of changing as we are moving into the era where we're actually doing surgery on these more aggressive prostate cancers and leaving the Gleason 6s to just watch and follow. So we'll see how this evolves over time. But that becomes difficult then. If you have that long of a follow-up, are you really going to impact survival with some of these agents? And perhaps some of these patients, especially if their PSA isn't going up quickly, you can probably just sit on these patients and watch and wait and wait, and hopefully not have to do anything for years. But once somebody develops metastatic prostate cancer, really that's where a lot of us have that's the trigger for us to start hormonal therapy. So where does prostate cancer spread to? Well, it typically spreads to the bone and the lymph nodes. However, it can go anywhere. Okay? Many patients don't have measurable lesions. In fact, only 40% of patients with metastatic prostate cancer have soft tissue disease. The rest of them have bone-only disease. So that is disease that is just in their bones. And that is not, we can't really measure how big those lesions are based on the bone scan. So it's difficult to do our traditional studies where we look for shrinkage of the tumors with prostate cancer. So actually PSA becomes a very good marker for us to see how a patient is doing in terms of their therapy. So let's talk a little bit about the cornerstone for treatment for metastatic prostate cancer. That really, it led to a Nobel Prize by Dr. Huggins here. And basically what he showed was that in patients with advanced prostate cancer, he took a large number of patients that had really advanced prostate cancer. And what he did was he was able to decrease their testosterone levels, either using estrogens, synthetic estrogens, which decreased their testosterone levels, or by doing orchiectomy. And he showed that the pain that those patients were having, the bone pain and everything, got dramatically better very quickly. And the tumor markers, and that was before PSA had been identified, but the tumor markers, alkaline phosphatase, came down significantly. What he did was something that probably wouldn't pass our IRBs today, but this was in the days before there was significant institutional review board authority. He gave back to those men, those same men that had the dramatic relief from their symptoms, he gave them back testosterone. Sure enough, their symptoms came right back, roaring back. The pain that they were having became much worse. So he showed very convincingly that testosterone was very important in driving prostate cancer growth and symptoms. And based on that, in '66, he won the Nobel Prize in medicine, or shared the Nobel Prize in medicine for that. So let's talk a little bit about hormonal therapy. What is it? Well, this is a representation of a prostate cancer cell or prostate cell. You see the cytoplasm here. Here's the nucleus, right? So the testosterone or dihydroxytestosterone comes into the cell. Within the cell, testosterone is converted to dihydroxytestosterone by 5-alpha reductase, and then it binds to the androgen receptor. This androgen receptor is in the cytoplasm of the cells, and once you bind the androgen receptor, you dimerize the androgen receptors, you get heat shock protein chaperones that will bring the androgen receptor into the nucleus, and it will bind to androgen response elements and drive the transcription and translation of the cell, and so you get growth, okay? Now this anabolic process is driven by the testosterone, so by knocking out testosterone, you're going to then inhibit all of this pathway and inhibit transcription, translation, etc. So there are several different ways we can knock out the testosterone by directly lowering the amount that's made in the body, or we can actually interfere with this pathway by hitting the androgen receptor with androgen receptor antagonists. And we'll talk briefly about both of these. So testosterone lowering therapies really depend on the fact that the gonadotropin releasing hormone made in the pituitary can be lowered. So if you give either a GnRH agonist or an antagonist, you can actually decrease the levels of testosterone. And that's because GnRH is released in a pulsatile manner. So if you give an agonist, it's going to actually be a little bit, you're going to get a transient increase in the testosterone levels before they drop to nothing. There's only one approved antagonist, daguerreolex, and it requires monthly injections rather than injections about every 3 months with the GnRH agonist. Orchiectomy is also another option. So this is surgical removal of the testicles. The testes is basically where you make 90% of the testosterone found in the body. So side effects of hormonal therapy or androgen deprivation therapy, there's a long list, but the main ones that you will hear men complaining about include the decreased libido, decreased sexual drive, and erectile dysfunction. Hot flashes are a big one. So it's similar to when women are going through menopause. Very similar in terms of the intensity and type of symptoms that they get from the hot flashes, and it's very similar in terms of the pathophysiology. And we treat that the same way we treat women going through hot flashes, or the similar types of therapies can be used. You can get some increased fat deposition and decreased muscle. You can get a little bit decrease in bone mineral density, like when women are going through menopause, so there can be an acceleration of the bone loss. And you can potentially get an increased risk for diabetes, and there's some controversy surrounding whether or not there's an increased risk for heart disease also. The other way we can interact with the androgen signaling pathway is by blocking the androgen receptor itself. So not lowering the testosterone, but actually interfering with the androgen receptor. Most of these drugs will go and they'll bind to the androgen receptor. The earlier classes of drugs just bound to it and prevented the testosterone from binding, or dihydroxytestosterone from binding to a certain extent. some of the newer agents, we'll talk about their benefits in just a minute. So all of them really have a similar mechanism of action, though. They bind to the androgen receptor, and they can decrease the go signal for the prostate cell. There's other hormonal agents. Ketoconazole is something that has been used for a long time until abiraterone, which was recently approved, came along. Both of these agents act by decreasing the synthesis of adrenal male hormones that can also drive the growth of prostate cancer cells. And we'll talk about that in a little bit. So now let's move to metastatic disease, our treatment options for patients with metastatic prostate cancer who now have started to have symptoms. So until 2004, really nothing had been shown to improve survival in men with prostate cancer that had metastatic disease. Very disappointing. There were some agents that were approved based on decreasing symptoms for these patients. And that was basically the mitoxantrone plus glucocorticoids. What they showed was that if you gave this older chemotherapy drug, you could actually improve the quality of life of men for a longer period of time than if you just gave the glucocorticoids like prednisone. So based on this, in 1996, the FDA approved mitoxantrone. And this became the standard of care, even though it didn't really improve survival. There were studies showing it didn't improve survival. It became the standard of care and helped men get through some of the symptoms that they were having. So because of that, it was used as a standard agent compared with this newer agent, docetaxel, which is a taxane, also known as Taxotere. And they gave two different schedules of docetaxel, every 3 weeks at a higher dose or weekly at a lower dose, versus this mitoxantrone. And all of the groups got prednisone with that to even out the arms. And what they found was that if you give the docetaxel, the Taxotere, every 3 weeks, you did get an improved survival compared with the mitoxantrone. The weekly docetaxel fell in between those two. So there was about a 2.5-month improvement in survival and about a 22% reduction in the risk of death if you got docetaxel. I should also mention that may be an underestimate of the true benefit because patients who received the mitoxantrone at progression were allowed to get the docetaxel, and about half of them did. So cabazitaxel was a drug that was just approved recently. Cabazitaxel is a different taxane. It's similar to docetaxel, but it appears to have activity even in docetaxel-resistant cell lines. And what they looked at was about 750 men with metastatic prostate cancer who had progressed after receiving docetaxel. And what they found was that there was more toxicity in the cabazitaxel arm compared with the mitoxantrone arm. And about 5% of the patients died actually because of the low blood counts and the infections they received because of that. But despite that, there was an improvement in overall survival. And you can see here about 30% improvement in the mortality compared with, overall survival compared with the mitoxantrone and prednisone. So based on this, the FDA approved this in 2012. Now let's talk a little bit about abiraterone. I mentioned that earlier, but this is something that was also recently approved in 2012. And what you can see here is that the way it works is by decreasing the synthesis of these male hormones, these androgens, both within the adrenal glands, and actually, interestingly, something that we've identified in the last 3 or 4 years is that tumors actually have these enzymes that can actually make the androgens themselves. So these prostate cancer tumors are making their own gasoline, right? They're fueling their own growth by making this. And so this abiraterone not only can lower the testosterone levels to very, very low levels in the serum, but they can lower the intracellular levels of testosterone substantially. And it appears that in patients that are treated with just standard hormonal therapy, the intracellular androgen levels can still be relatively high. So in this publication in the New England Journal of Medicine in 2011, you can see that the overall survival was substantially better. You see a 35% reduction in the risk of death if they got abiraterone versus placebo, and this is following chemotherapy. The time to PSA progression was also longer, 10 versus 6 months, and the progression-free survival, 5.6 versus 3.6 months. All of these favoring the abiraterone, and the PSA response rate, the number of patients who had declines in PSA of at least 50% was substantially better if you got the abiraterone versus the placebo. So based on this, the FDA excuse me, approved abiraterone for prostate cancer. Now we'll talk about the final hormonal therapy agent that I want to mention. And this is another agent that is an androgen receptor antagonist that was recently approved based on improved overall survival in prostate cancer. So in the last, as I'll show you in a little bit, in the last few years we've had a large number of approvals in prostate cancer. So this is enzalutamide, androgen receptor antagonist. So turns out it has a really high affinity for binding to the androgen receptor. Bicalutamide, I would say the standard of care, 80% of the market share of androgen receptor antagonists before enzalutamide. You can see its dissociation constant here. Much better with enzalutamide, also called MDV 3100. Not as good as dihydroxytestosterone, which is the gold standard. But you can see there's less likelihood of this androgen receptor complex being imported into the nucleus if you have enzalutamide bound to it. It doesn't bind at all to the androgen response elements, so it can't initiate transcription translation, whereas with bicalutamide you do get some. And there's no coactivator recruitment, like whereas you do get some with bicalutamide. So what did this drug look like? Well, early on in the initial phase 1 and phase 2 studies, what you saw was that there was a substantial proportion of patients that had nice decreases in their PSA with this agent. And these are much better than you'd see with chemotherapy, for instance. You see about a little over half of the patients, whether they're chemotherapy naive or after chemotherapy, had declines in their PSA of at least 50%. And so in another landmark article published last year in the New England Journal of Medicine, you see that there was improvement in overall survival, time to PSA progression, and radiographic progression-free survival if you received enzalutamide. And this looks even better, I would argue, than the abiraterone data. Okay. The last approved, well, no, we've got 2 more approved agents, but the last agent that we're going to talk about that's a cytotoxic therapy is alpha-radin. Now, patients with metastatic prostate cancer, as I mentioned, they often have disease that is predominantly, if not solely, visible in their bone. And you can see this is a patient, this is a bone scan. You can see multiple lesions here on the skull. These white areas represent prostate cancer lesions. Here's the ribs, and here's the frontal view, and you can see a lot of uptake in these different areas associated with prostate cancer. So there is a bone-seeking agent that was just approved this year called radium-223, and alpha-radin was the name that it used to go by, but it's now called Xofiga, and that's with an X. But what you can see is it's a calcium mimetic. If you look at the periodic table, it's in the same row as calcium. So this radium looks to the body like calcium, So anytime that there's active ongoing turnover of bone, it's going to pull in this radium in there. And in these osteoblastic lesions that prostate cancer tends to have, there's lots of ongoing active turnover and incorporation of the radium then into the bone. And because it's an alpha emitter, it will go in and it'll actually kill the cells that it comes into contact with. So again, this was published in the New England Journal of Medicine just this year, just a few months ago. And you can see here overall survival substantially better than placebo, and time to first symptomatic skeletal event, and that's a very good clinical endpoint, also substantially better. So in the final few minutes, we'll talk about therapeutic vaccines. Now, this happens to be the area that I like the best, and in the area that I'm involved in my research here at the intramural program. There is one approved therapeutic vaccine for prostate cancer, and that is Sapulosel-T, also known as Provenge, the trade name. What is this agent? Well, the idea behind this agent and all therapeutic vaccines is to develop an immune response whereby the patient can recognize and attack the tumor. Their immune system can recognize and attack the tumor. How do they make this particular drug? Well, you take a patient, that patient undergoes apheresis, that is removal of blood. Then they spin down the blood and they just take out the white blood cells and give the patient back everything else, the plasma, the red blood cells, the platelets, etc. And then they ship this product to a central processing facility. And then what they do there is they take a target, in this case prostatic acid phosphatase that's found on virtually all prostate cancer cells, and they have a fusion protein of that target plus GM-CSF. GM-CSF is granulocyte monocyte colony stimulating factor. It's an immune stimulant, and they put that in with these cells, and that causes these white blood cells to become activated, and the antigen-presenting cells within that can become activated, and when given back to the patient, then the idea is that will generate an immune response. This entire process takes about 3 days, and the process is repeated every 2 weeks for a total of 3 times, so over a period of about a month, and that is an entire treatment course for the patient. So pretty logistically complicated, but there was a large phase 3 study that enrolled patients, and they received either this vaccine or placebo, and the primary endpoint in the study was overall survival. And what you can see is that patients that received the vaccine actually lived longer. There was about a 22% reduction in the risk of death, and the improvement in survival is about 4 months. So based on this, the FDA approved Sapulosel-T. What we're working on here is a different strategy. So rather than going through all the logistical, complicated processes of doing the apheresis, we're taking an off-the-shelf approach. So we've engineered a viral vector that has the genes for PSA. Now remember, PSA, prostate-specific antigen, found in virtually all prostate cancer cells, as well as genes for 3 different human T-cell co-stimulatory molecules that really get the immune system revved up. And we can put that into a viral vector, and then what we can do is we can simply take that out of the freezer, thaw it, and inject it into patients. So just really easy, just like you'd give a flu shot. So it's logistically simple, but immunologically advanced vaccine. So there was a randomized phase 2 study, very similar to the design for the IMPACT trial, the Provenge trial, where the patients got vaccine versus empty vector, and the progression-free survival was the primary endpoint. Overall survival was a secondary endpoint. But what was interesting with this is the overall survival data. And And what you can see here is that there is a nice improvement in overall survival, about an 8.5-month improvement in survival, and a 44% reduction in the risk of death if you receive the vaccine. So this has led to an ongoing phase 3 study. But what was interesting with this study and with the Provenge trial, what they both had in common was that there was no improvement in progression-free survival. So the overall survival was clear and it was significant and was clinically meaningful. But the progression-free survival, the time until the patient's disease started to get worse, was not any different between the two arms. And there was no substantial decreases in PSA like you saw with the enzalutamide or the abiraterone. So I think it's important when we think about what might be going on here to think about the differences between therapeutic vaccines, immunotherapy, and conventional cytotoxic therapy. So first of all, cytotoxic therapy directly targets either the tumor or the microenvironment, whereas immunotherapy doesn't. It actually directly targets the immune system, which then in turn targets the tumor. So perhaps in part because of this, you may see a delayed response. And in fact, we see that often where patients getting some of these newer immune checkpoint inhibitors, they have disease that actually gets substantially worse before going down to nothing. With therapeutic vaccines, you expect to see a memory response. That's in fact one of the goals, but you don't expect to see that with conventional therapy. You don't prime an immune response efficiently with conventional therapy. Conventional therapy is often limited by toxicity. Unfortunately, that's not the case with therapeutic vaccines. But perhaps in part because of this delayed but perhaps prolonged response, you might see a completely different kinetic profile of a clinical response following immune therapy. And so to look at that, we looked at about the last 10 years of data that we have from the intramural program in patients treated with prostate cancer clinical trials. We looked at hormonal therapy trials, at chemotherapy trials, and at immunotherapy trials. And at the two extremes, what we found was when we came in with our most aggressive chemotherapy regimen, what you'd see is you'd see a dramatic decrease in the tumor volume in the majority of patients treated. It would remain down for a variable period of time, but when they started to progress, you could pretty accurately define when the patient was going to die, and that growth rate was pretty much identical to the growth rate they had starting on study. But when you came in with a immunotherapy, what you saw was something different. You didn't see this big dramatic decline in the tumor growth rate in the the tumor volume in the majority of patients, but what you saw was an eventual slowing down of the growth rate that could translate potentially into improved survival. So that, of course, brings to mind the old childhood fable of the tortoise and the hare, where slow and steady may indeed win the race. So this is just one example of a patient that had treatment with Prostate, the PSA TRICOM vaccine. And you can see early on when they were diagnosed, here's about the rate their PSA was going up at. They had surgery. PSA came down nicely. However, when it started to go up, you can see it's growing up at about the same rate here. And eventually, they had vaccine, an initial 3 vaccinations. And you can see the PSA kind of continues to go up for a little bit, then comes down beautifully. But when it starts to go up again after the 3 vaccines, it's going up at a much slower rate. They got IRB approval to give the patient another 3 vaccinations, and you can see here it appears to have flattened out again. And in fact, in follow-up data from that will be coming out this year, it's in press right now, the PSA has actually dropped down to less than 4. So how do we put the vaccines into juxtaposition with the other approved therapies? Well, what you have is the chemotherapies, vaccine, hormonal therapies, and the alpha-radin just approved this year. So all of these agents approved relatively recently. You can see a decrease in the hazard ratio between, which is a decrease in the risk of death. So you get a 24 to 37% reduction in the risk of death. Improvement in survival between 2.5 and 4.8 months. With PSA TRICOM, Prostate, you get a 44% reduction in the risk of death and a 8.5-month improvement in survival. But this is just based on phase 2 data, so there's a phase 3 trial going on right now. What I would also point out is that the number of patients that have to stop due to adverse events, very low with the vaccines compared with the other therapies, but also the proportion of patients that have declines in PSA, very low in the vaccines compared with the other therapies, as we already mentioned. So based on this data, there's an ongoing phase 3 trial that will enroll 1,200 patients looking at overall survival for prostate. So what we've talked about is, we've talked about treatment for localized disease, radical prostatectomy, radiation, and brachytherapy. We've talked about hormonal therapy. Standard of care is to combine it with radiation therapy for patients with high-risk disease or lymph node disease following radical prostatectomy, and in patients with metastatic disease as primary therapy. We've also talked about vaccine therapy, Sapulosel T, about chemotherapy for patients with more advanced, perhaps reserved for symptomatic prostate cancer, metastatic disease. We talked about these brand new agents, 2 hormonal agents, abiraterone and enzalutamide, and this radium-223. And finally, what we didn't talk about was zeledronate or denosumab. Those do not improve survival for men with prostate cancer, but they can decrease the chance of them developing skeletal-related events from their prostate cancer. Thank you, and I'd be happy to answer any questions you have. Yes? It's a good question. So the question was, can you get vaccinated for prostate cancer before you're diagnosed as a preventative vaccine? So most of us, when we think of vaccines, think of prevention. We think of the flu vaccine to prevent you from getting flu, or the hepatitis vaccine to prevent you from getting hepatitis, or the cervical cancer vaccine, the HPV vaccine that hopefully is going to eradicate cervical cancer as we know it now. So yes, in theory, these vaccines could work to generate a potent enough immune response that could decrease the chance of getting prostate cancer. I don't know that we are ready yet to do a trial of that magnitude that would prove effectiveness of this. It's going to take a vaccine like what we have that should be a lot cheaper to do. I should just mention that there has been some controversy with the Sapulosel T because this vaccine, because of the logistical issues associated with it, it is very costly. It's about $93,000 for a treatment course. So that works out to about $31,000 per vaccine, and then you get 3 of those over a period of 1 month. Other questions? I saw a hand up. Yes?
Is it possible to use this vaccination to sort of treat metastatic?
Right, so it's a good question. So could you treat benign prostate conditions with this, or could you treat precancerous lesions with this in somebody that's at high risk for developing cancer? And the answer is potentially. We actually are talking with the prostate cancer prevention program to see if perhaps we can use this in patients. We might actually try it first in patients who are candidates for active surveillance, and then see if we can come up with parameters that would enable us to do a larger study. The parameters would be, can we take and decrease the proportion of patients that go on to get surgery, or if we can prevent them from having to go through a morbid procedure, radiation or surgery, then that's a good thing. So perhaps we could, by generating an immune response that can wipe out some of these bad acting cells, we could prevent or delay that, and that would be a good thing. For other benign conditions, potentially one could use this. You know, could you one day be able to get a vaccine that's potent enough or modulate the immune system that's in a way that's potent enough so that you could do a removal of the prostate by the immune system rather than by surgery? And, you know, it's not, it's, you might say, well, that's science fiction. Well, stay tuned, because there's some of the things we have going on are really looking interesting. So potentially, there's certainly patients that get organ transplants. We know that the body's immune system is capable of completely annihilating that organ if you don't calm it down. So yes, that is, you know, how to turn on the immune system and get it to react just to that. I think I think that within the next decade, we could make significant advances towards that. Other questions? Yes? Yes? So two things. So the ketoconazole is FDA approved for fighting mycosis, so fingernail fungus, other funguses. So it's the same mechanism that's used to fight to fight fungus. So it's a sterol. The steroid enzymes are hit, but it's at much higher doses than we use to fight fungal infection. So this at these higher doses, it affects a lot of the adrenal steroid synthesis, and by doing so, shuts down several things. It can shut down not only the androgens and other sex hormones made in the adrenal gland, but actually it can also shut down the glucocorticoids too. So that's why it's given usually with hydrocortisone as a replacement steroid. Because of the issues with ketoconazole, there's a lot of drug-drug interactions. So it's probably soon to be relegated to the history books in the treatment of prostate cancer, because with abiraterone, there's much fewer side effects. There's activity even in patients that have failed ketoconazole, whereas if you give abiraterone and then you add ketoconazole to the patients that have progressed on abiraterone, there's really no responses. So it appears to be more potent, less side effects, less drug interactions, and it improves survival, whereas that's never been shown for ketoconazole. Thank you very much.